Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with Montgomery County health issues? Find out more right now. My guest this evening is Dr. Aruna Nathan, a noted internist in Montgomery County and currently president of the Montgomery County Medical Society. Aruna, welcome to House Call.
Thank you so much, Dr. Doman, for having me.
It's our pleasure. So briefly tell our viewers about your professional background.
Sure. I am an internist, as you pointed out, and I'm also a lifestyle medicine physician. I have been in practice for over 25 years, and 25 years in Montgomery County. And I was mostly in private practice. And now I work in an organization in Prince George's County called Absolute Care. And we care for patients who are they have very high social needs, and they're also very high disease burden. My job now is to bring lifestyle medicine to them. And
Explain to our viewers what exactly is lifestyle medicine.
Sure. So lifestyle medicine is actually, there's an American College of Lifestyle Medicine that was initially started in 2004. And the focus is on all the chronic medical conditions. So that's the reason it interests me. As an internist, over the years, I've cared for patients with multiple chronic medical conditions like diabetes, heart disease, hypertension, and kidney disease. And so with lifestyle medicine, I'm able to provide better care for them. So what lifestyle medicine does is it focuses on areas like nutrition and our diet, physical activity, sleep, how we deal with stress, and the community, and also risky substances like alcohol and nicotine. And it allows us to blend this into their treatment plan in a more holistic manner. So we're just not giving them advice about you need to eat healthier, but more specific discussions. And the whole interaction with patients with lifestyle medicine becomes more of a partnership rather than just a physician-patient relationship. And that also seems to help because we use tools like motivational interviewing. So overall, it just helps deliver much better care.
Very nice. And clearly you must have a kind heart to focus on that part of patient management. Do you do this only for your own patient population, or is it also that you get referrals from other internists in the community where they want you to help that part of their management?
When I was in private practice, I was mainly doing it for my patient population. But over the years, because of the nature of the practice, patients would self-refer themselves, or practitioners and specialists who knew about the practice would refer patients to us. And that was it was wonderful. But at the same time, it was mainly taking care of patients who were motivated, who wanted to make those changes.
Sure.
But that's not what lifestyle medicine is about. It's about making sure that it's available for everyone. And most people have not heard about it. And so where I am right now, most of the patients, when they come in, they don't even know what lifestyle medicine is. They're coming to me for high blood pressure or diabetes or heart disease. And then I'm introducing them to lifestyle medicine and bringing that in. And now I've been in this current position for over 2.5 years. And we have, for the last over 2.5 years, a group medical visit that we've been conducting on a regular basis. So we meet with some of our patients every other week or every week in a group setting. That referrals for that is from everybody, not just my patients. And I do get referrals now for mainly patients who want to work on their lifestyle.
Very nice. So What kind of resources do you have besides yourself to adopt these important lifestyle changes?
So that's a very, very important question because none of what I'm doing can be done just by, you can, but it is more difficult to do when you're by yourself. But there are ways to go about it. So when I was in private practice, I had a nutritionist who ran her classes in my clinic after hours. So I just provided her the location. And so she could have any patients, but they were mostly patients from my practice. And so you can collaborate with someone in the community. And similarly, I had even hired a part-time health coach for the same reason. But then now that I work in this organization, we have a big team. There's a behavioral health therapist who sees patients with me. We have a nurse who's a care plan manager who can see patients with me. And so it's a much larger team. And we also have chefs that come in to do demonstrations for, using food in a way that it really helps you. And at the same time, it's very tasty and interactive, the whole session.
Sounds like a wonderful thing you're doing. Now we're going to shift gears to the topic at hand, which is Montgomery County and the state of Maryland health issues. And we'll start out by once again reminding our audience you are president of the Montgomery County Medical Society. So for starters, share with our viewers what exactly is the Medical Society and how does this differ from MedChi, the Maryland State Medical Society, and the American Medical Association?
So the Montgomery County Medical Society is a county medical society. It represents over 1,500 medical doctors who either live or practice in Montgomery County. So we are much more grassroots, much more local with our issues, but we align with the State Medical Society, which is MedChi, and with AMA. And we are we try to bring about changes using legislation, but it's a grassroots organization. So we listen to our physician members, and what they are trying to do is to provide, or their commitment, and our commitment as a society is to provide good health care to the residents or to the citizens here.
So clearly, you not only represent physicians in Montgomery County, but at the same time, you very much serve as patient advocates.
Yes. Yes.
So share with our viewers some of that role for patient advocacy and how you also work with the Montgomery County Health Department.
Sure. So with the Montgomery County Health Department, it's a pretty good partnership. So the health officer for Montgomery County Health Department now is Dr. Keisha Davis, and she is on our board, that is the Medical Society board. And our past president, Dr. Berger, served on the Health Commission for Montgomery County, and now I do the same. And so we actually work very closely, and we know about issues, we know about what they can offer, and so we align really well. In terms of what the health department offers, we have a webinar. So Montgomery County Medical Society actually has a webinar for the physicians to know what services are available and how to refer the patients. And this kind of close alignment really came, it was really good during COVID times. And we know because of COVID that we need to be prepared. And so first and foremost, we try to help our physicians run their practices smoothly so they can serve their patients, right? And then we have some other things like a prescription drug card that is through the State Medical Society that helps with discounts on some prescription medicines. There's a physician find a website where you can find physicians in Montgomery County and match patients with physicians. One of the things that I really like, or I want to explore more in my presidency, is the Patient Activation Network, or the Patient Action Network, PAN, and what that is focusing on is more of health education, health literacy education, because many a times there is problems with access to care for for patients. And so how do we go about that in things like prior authorizations, or if there's a story that they need to get out, so that, so that's so through PAN that is possible. But above all of this, I think we are just a very vocal bunch. The Montgomery County physicians in the society, and we always speak up about things like Medicare and Medicaid and other aspects that affect patient care delivery.
Sure. How do you, as a county medical society, then interact at the state level?
So we start local, right? We engage. So our current new plan, right? The new plan that from 2025 strategic plan is we connect, engage, and then empower. So the empowerment part is mainly the engaging, having the physicians engage actively in legislation, which occurs at the state level. But we start at the county level with the connectivity part and engaging part. So listening to our physician members, listening to what concerns they have, trying to see if there's some commonality, and then coming up with some written statements, and then going and taking it to the state level. And so that's how we work with the state level. Many a times the state MedCai might ask us to kind of research or do a survey on a few things, because we are actually working closer to the physicians.
We have 2 minutes left, so before we go on to the break, tell us the Medical Society's reaction to the Health Secretary, Robert Kennedy Jr., eliminating the committee that oversaw and made recommendations about vaccines and replacing it with one that is already preloaded with people that oppose vaccines.
I think that was June 6th or so, and that's the advisory committee for
immunization practices.
Immunization practices, yes. And so that was very concerning because so many of them were let go. And what that is it's a committee that is made up of physicians, pediatricians, epidemiologists, citizens. They're all they're independent. They review a lot of scientific data and papers, and it's very transparent because all of this is available to the public. After doing all of this, they make recommendations to the CDC about vaccine schedules. And so it's a very rigorous process, a scientifically rigorous process, and it's transparent to the public. And that is what makes it so important. So definitely concerning. And it causes a lot of confusion. Lots of physicians are hearing from their patients about vaccine questions. And so what we are saying in the society is to make sure that you have people talk to their physicians about vaccines so they get all of the answers.
Sound advice. We're going to pause briefly for a public service announcement. More with my guest, Dr. Aruna Nathan, president of the Montgomery County Medical Society. We'll be right back.
Life doesn't always give you time to change the outcome. Prediabetes does. One in 3 adults has prediabetes, and you could be one of them. There are usually no signs for prediabetes, so it's important to understand your risk. With early diagnosis, prediabetes can be reversed. And you can change the outcome. Take the 1-minute prediabetes risk test today. Go to doihaveprediabetes.com noteworthy.org.
We're back, and my guest this evening is Dr. Aruna Nathan, president of the Montgomery County Medical Society, and we are making our annual review of Montgomery County health issues. So, Aruna, let's shift gears now to discuss the so-called AHEAD model. What is that all about?
So the AHEAD model is something that was it's put forward by the CMS, and Maryland is one of the few states that is adopting the AHEAD model, and it's going to start from 2026, and I believe it goes all the way to 2034. The main focus of the AHEAD model is on strengthening primary care, improving prevention, better management of chronic medical conditions so that we catch things sooner. One of the focus of the AHEAD model now is to build tighter relationships with the hospital and the community. And that will help in better managing the patients, because when a patient is transitioning from inpatient to outpatient, may it be to the house or a nursing home or a rehab facility, that's when many things can potentially go wrong. And having that good transition of care, building a really strong primary care network and infrastructure will help keep patients healthier and away from acute settings.
Another important aspect of the recent legislative session was MedChi's annual advocacy in terms of defining health professional scope of practice. Share with our viewers what exactly is that concept, scope of practice, and why is it important for patient safety?
It's a very, very important discussion. So overall, I would say that when you say scope of practice, it means, so say you are a gastroenterologist and you are trained to do more of colonoscopies, upper endoscopies. We refer patients who are more, things that are more difficult to understand, a chronic diarrhea, pancreatitis that is chronic. So you have additional years of training for that. And so I know when I should refer my patients to a gastroenterologist or to a cardiologist. And so scope of practice is what you are trained to do and what you practice. And what is happening now is we do have a lot of shortage of physicians in many areas. And people are trying to figure out how to best solve that problem. So in doing so, we have non-physicians who are also beginning to play roles of physicians, and they have a structure, and they are, for PAs and NPs, there's a structure, they are supervised, and then they get to that point, right? So it's important that we have all these guard rails in place when it comes to practice of medicine. I think all of us function really well as a team, but we need to know our limits and know when to refer our patients so that we can practice under, keep our patients really safe and give them the best outcomes.
Well said. There is, by the way, data out of Canada where if colonoscopies are performed by family physicians who are not as well trained, of course, there is a higher risk of missing pathology and, unfortunately, a higher risk of complications. So that just serves to show that only proper training should allow a healthcare professional to provide their specified skill set.
Yes, and even with a specialty like internal medicine, we are managing patients on multiple different medications. They have varying kidney functions, they have varying liver functions. So things can go wrong unless you are completely trained in managing all these different medications. And we have to alter doses. Sometimes we have to hold some medicines when we are treating them, say, for example, with an antibiotic. And so there is a lot of training that goes into this.
So the Maryland legislature recently passed a law requiring insurance coverage for calcium score testing as a preventative measure for heart disease. Share with our viewers the significance of this test.
Sure. So the CAC score, or the calcium score, is a preventative test of sorts. It is a test that you do when you are trying to assess risk for coronary artery disease. And it's especially useful when we are trying to stratify a patient, or to figure out when a patient should be on, whether they need to be on a statin, like atorvastatin or Lipitor or Crestor or rosuvastatin, or we can wait and then rescan them in a few years. So this is a test that is recommended by American Heart Association, American College of Cardiology, and until recently, I think May of 2025, it was not freely available to to candidates with certain insurances. And now that it is mandated that it should be covered, it really helps. So everyone can get that test as long as they, meet the needed indications for the test.
Let's go on then to discuss another very important advocacy MedChi and the Montgomery County Medical Society enrolled in, which was coverage for insulin by insurance companies for diabetic patients. I would think, and I'm sure many of our viewers think, this should be intuitively understood that if oral agents are not adequate alone, that it should automatically be covered for insulin. Share with our viewers the scope of the problem and what was the advocacy that the Medical Society led.
So there are various types of insulin right now in the market, and it is difficult when we have to switch patients between brands, especially when their sugars are well controlled. And this policy came into place mainly for that, so that there is no lack of treatment for some time. What usually tends to happen is that a patient is going to be running out of insulin, and then you write for a refill. And that particular brand is then sometimes not covered by the insurance company, even though they've covered it for the last 2 years or more. And we may not always have access to that information right away. So we may not know that it's not covered. So the patient goes to pick up the prescription in the pharmacy, and then they say, hey, it's not covered. And then they will send us a note or a fax or a now electronic, response that it's not covered. So then we have to look through the PA process, prior authorization process, or we try another brand which is equivalent. And then that process can be delayed quite a bit. And in the meantime, the patient is without insulin or does not have adequate insulin, sugar is not well controlled, putting them at risk for other conditions. And so with this new the new bill, we are able to continue with the same brands if it's working, right? And also when they change insurances for 90 days, they have access to that.
Now, another important advocacy provided by the Society in the last legislative session was providing insurance coverage for hearing aids. Share with our viewers that legislative battle and what happened.
So that was really a great victory because, we've had so many patients over the years who,
yes,
they need hearing aids, and then by the time, they're ready to get the hearing aids, they find out that it's not covered. Or they may not have adequate coverage. So they may get certain hearing aids and they may not get a few, they may not get the right kind of test. So having hearing aids covered by medical insurance and not treating it as not part of the medical insurance, like vision or dental, it is huge because the hearing is so important, especially as one ages, and studies are showing more and more how it can cause, when you have decreased hearing, it can cause social isolation, increased depression, affects the memory. So it really has a lot of implications. And so now that we are able to get hearing aids under medical insurance is a big win.
Yes. And I might also mention that there's data to show that extended hearing loss raises the risk not only of memory loss, but dementia.
Yes, exactly. Dementia. Yep.
Yeah. So there was another important advocacy done in the last legislative session, and this was more on behalf of the physician community, and that is clarifying non-compete clauses. What exactly does that refer to, and what was the end result of the lobbying?
So the non-compete clause is something that was in place for many years. And so say a physician is part of a group and then were to leave, then they may have some restrictions on where they could practice again. It could be 5 miles, 10 miles, and it could also be for a few number of years. That is the non-compete that they have signed. And the reason it was an important issue is because we want to make sure there's continuity of care and access to care for patients. And so they made some changes, and I don't know the exact dollar amount, but there is a cutoff. So any physician making less than that amount, they don't have that clause, or they shouldn't have that clause. And if it is over a certain amount, they have reduced the number of miles and also decrease the number of years. So mainly to solve the access issue.
Sure. So we have 2 minutes left, and I want to ask you a very important question. And that is, unfortunately, President Trump and the Congress, with exclusive Republican votes, have passed the big, beautiful bill. One of the consequences is that they have slashed Medicaid funding, which will include, of course, the state of Maryland. What has been the reaction of the medical society to the loss of Medicaid funding? And what is your collective concerns about patients losing health care statewide? You have 1 minute.
Okay. So the patients that I care for right now, they're all the Medicaid population. So for the last 2.5 years, I've got to work with them very closely and really know them. And they are patients who are the most vulnerable. And when we, as a state, Medicaid covers up to 1.6 million people. And most of these people are seniors, they are children, they're people with disability. So when they lose medical access, it's going to have enormous ramifications, not just in the health systems and in the ERs or in the pharmacy, but it's going to affect all of us in multiple different ways. It's not just through Medicaid, it's also through their SNAP dollars that they depend on for nutrition. And so we are, as a community of physicians, we are extremely concerned about this. And it seems a little short-sighted, and we really have to look at the bigger picture.
Thank you for that closing statement. Thank you once again for serving as our guest this evening. My thanks to my terrific staff at the studio for making this program work. And my thanks to you, the viewer, for joining us this evening. If you have any questions or suggestions, you can reach me at this website. In addition, if you have any questions for Dr. Nathan, there will be information provided on the screen as well. As for our next show, we are looking forward to having a guest review the question, why are African American women experiencing higher risk during pregnancy? It's going to be an important social topic. See you then next time for another edition of Housecall. Good evening.